want to talk a little bit about the clinical setting first. And so, Bertrand, maybe you can start us off just with the clinical, phenotypes of metastatic, hormone-naïve or hormone-sensitive prostate cancer, and what are some of the prognostic factors? What are some of the parameters we think of when we're evaluating that population?
I think that it's very, what I'm impressed by is the fact that what we're going to discuss now has been already identified like 15 years ago. So when SWOG planned the intermittent androgen deprivation therapy, very famous urologist Mark Soloway came with, you've got 4 or more bone metastases. So clearly, in terms of prognostic marker, the volume matters. That's clear. The number of bone metastases, the presence of absence of visceral metastases, clearly volume matter. The problem is the ongoing discussion about changing this prognostic marker into predictive marker. That's going to be a not totally different question. Beside that, there are factors which are less discussed because probably they're more difficult to apprehend, which is the ECOG performance status or the frailty level of the patient. We are very surprised that actually in most of these trials, the number one exclusion criteria we're facing every day is the frailty of these patients. So there's a lot of work to be done. And if you look at the STAMPEDE, there was a push a few years ago to the STAMPEDE team to produce the result of the placebo group to kind of get a better understanding of the prognostic marker. And clearly, that was size and location of metastases. It was the ECOG performance status, the Gleason score, but you don't need to be a genius to know that it correlates to some extent with air sensitivity, and presence of absence of pain. On top of that, there are other which are not that often measured, but have been shown by the French as one of the number one prognostic marker, at least in terms of power. This is alkaline phosphatase. This was shown in the GTOC15 trial by Gwenaëlle Gravis when she used an old model, which is the GLASS classification, which is basically taking extent visceral disease. But clearly these are the most important, and this, anybody collecting data should report that, because otherwise we can't clarify. Because to me, if you've got 5 bone metastases, and you've got a Gleason 7, and you've got normal alkaline phosphatase, I would put you at less risk that if you've got 2 bone metastases with alkaline phosphatase at 250 and a Gleason 9, because usually when you do a whole body MRI to these patients, you see a lot of. So we're going to have to play with that. But the question that has been dominating the debate in the last 4 years has been volume-centric.
So let me pick up on that. I think that's a really good framing. Thank you, Bertrand.